Good evening, everyone, and welcome to Second Opinions. Investigators discuss how they apply available clinical research in the care of patients with non-small cell lung cancer with an EGFR mutation. Due to unforeseen circumstances, Dr. Love will not be attending ASCO in person this year. My name's Helena Yu, and I'll be moderating the meeting this evening. And this is our faculty today. We have Corey Langer, Philadelphia, Jonathan Goldman, UCLA, Josh Sabari, NYU, New York, Zofia Piotrowska from Boston, and Joel Neal from Palo Alto. Welcome. Here are relevant faculty and research to practice conflicts of interest. The program will contain discussion of non-approved uses of agents and regimens. Please refer to official prescribing information for each product for approved indications. So Research to Practice is hosting a total of 9 live meetings associated with ASCO 2024, and this evening's program is the second. We hope you'll be able to attend all 9 events, either live or virtually, over the next few days. All right, so in order to make this meeting more relevant to participants, Dr. Love also interviewed 2 other physicians, Dr. Roy Herbst and John Haymack, during which they posed cases and queries on a number of key clinical issues. Video excerpts from these interviews will be featured throughout the program as well. So this is where we're headed this evening. We're going to start out with Dr. Langer, who will be discussing non-metastatic EGFR mutant non-small cell lung cancer. Then Dr. Goldman will talk about first-line therapy for metastatic disease. Then I will discuss the emerging role of antibody-drug conjugates. Dr. Sabari will address other novel strategies for relapsed disease. Dr. Piotrowska will talk about the management of patients with EGFR exon 20 insertion mutations. And Dr. Neal will finish out discussing management of toxicities. We're going to start with a few videos.
Good evening, everyone. I'm Neil Love from Research to Practice, this year participating in our ASCO programs virtually. Over the last few weeks, I worked with investigators, Dr. Roy Herbst and Dr. John Haymack, to develop some interesting and provocative questions for the faculty on the stage to consider, beginning with Dr. Herbst, who wants to know, of course, how you're applying the most recent findings of the ADORA trial to your clinical practice.
I can actually use all your help. I actually saw a clinic today, and patients with 1A disease come in, and they have an EGFR mutation. Should those patients get osimertinib? We're waiting for the ADORA 2 trial, but the question is, what should we do in that situation? The other thing that commonly occurs is that patients have one of the non-canonical mutations, not the typical exon 19 or 21. We only looked at 2 different mutations in the ADORA trial. How should we deal with those patients? And the same would apply to the LAURA trial, because that also was somewhat specific. This is something in the real world that all of us are dealing with on a daily basis. You know, in stage 1A disease, 80–90% cured. So the question is, what is the role of osimertinib in that setting as an adjuvant? What's the role of chemotherapy? I'd love to know your thoughts on that.
What do you do for your patients who maybe do fit the criteria, let's say a stage 3A? When you get to 3 years, if they say, well, why would I stop it? I know the likelihood of recurrence is high and I'm tolerating it very well. So what do you tell those patients who are asking you why they should stop it after 3 years?
All right. So first question is, are there any circumstances where you would use adjuvant osimertinib for a stage 1A disease for a canonical EGFR mutation outside of a clinical trial? Corey, I heard you chuckle, so.
So this is a question that comes up. A lot of these folks, some of them have been detected incidentally for other conditions. Until I see the results of ADORA 2, I am not yet ready to commit patients to 3 years of potential toxicity. Remember, the prognosis in this group is still pretty good, baseline, 85% long-term survival. So it's going to take a pretty powerful improvement to actually show a significance in this situation.
Anyone disagree with that? All right, rare consensus.
The only thing that there are some changes in the staging where now we're just counting the invasive component of the tumor. So there are some cases that now are stage 1A but would have been 1B, and I'm having that complicated discussion with patients. But mostly I agree with Corey.
Joel?
Wait to see the data.
I mean, the other thing I think about sometimes is, certainly for very small tumors, less than a centimeter, non-solid tumors, I think the risk of recurrence is incredibly small. But for those 1 to 4 centimeters that ADORA 2 will inform us, I wonder if we shouldn't be thinking about like MRD testing and looking for evidence of residual disease in the blood. When we find MRD, that's like micrometastatic disease, so that's no longer stage 1A in my mind, but this is a question that we could ask of our patients after surgery. And MRD tests done serially every 6 months, there's very little risk.
We're going to talk about that, and I'll call on you, Joel.
With Sunday's plenary presentation of the LAURA trial, it's likely that people are immediately going to reconsider their management of patients with EGFR mutant, locally advanced, non-resectable, non-small cell lung cancer. And Dr. Haymock is curious about how you're thinking through its clinical application.
A common situation that we see is a patient presents with EGFR mutation that is locally advanced, potentially resectable, particularly if they have a good response. And the question is, what's the approach for this? Do we just follow the regimen of combined chemoradiation and then follow the results of the LAURA study that we know is positive? Do we consider induction therapy or neoadjuvant therapy in hopes of making them resectable? So the question is, what's your approach for EGFR mutant patients with initially locally advanced disease?
All right, so I think a few questions here. I think for patients that you would currently, is there anyone that you would offer osimertinib in lieu of adjuvant chemotherapy? We know this is happening a lot in other places. Zofia?
Generally, I try to make the decisions about adjuvant chemotherapy separately from the decision about adjuvant osimertinib. For the vast majority of patients, I don't think that the ability to use adjuvant osimertinib kind of allows me to skip the chemotherapy, if you will. I think we have to keep in mind there's a survival benefit for adjuvant chemotherapy for these patients. And, the ADORA study really didn't ask that question. These patients were supposed to get adjuvant chemotherapy per the investigator's discretion, although we know not all of them did. I will say that I have had some patients who are kind of borderline for chemotherapy or maybe are hesitant about it. And for those patients, there have been situations where they say, you know what, if I have another option, this is going to tip me towards no. But I do think that we, have to make those decisions separately. And we can't kind of give ourselves permission to skip the discussion about chemotherapy just based on the ability to use adjuvant OC.
I totally agree. Corey?
Pretty much the same, but I will make an exception for the smaller 1B patients. Giving adjuvant treatment to 1B 4 centimeters or larger is pretty much a North American phenomena. When you go outside the US, go to Europe, go to East Asia, those folks are generally not getting systemic adjuvant chemotherapy. They reserve that for N1 and N2, and there I will not deviate from giving chemo if they're N1 or N2. So there are exceptions, certainly if they're relatively frail or they can't tolerate treatment, but by and large, most of these folks will get adjuvant platinum-based chemo before they start OC.
I think another relevant question that I'm getting in my practice, which I'm sure you all are too, is what about an atypical EGFR mutation like a G719 or an S768I with higher risk stage 2 or 3 disease? What are you all doing in practice? Josh?
So it's interesting. I think that these uncommon mutations have different response rates, different durability to different therapies. So, for example, an L861Q may be a very responsive, mutation to osimertinib. So that patient, I might give adjuvant osimertinib. But G719 or S768I, those are, patients who in the metastatic setting, I would generally use afatinib or put on a clinical trial. So I'm oftentimes avoiding osimertinib in that patient population.
Anyone disagree or have a different opinion?
No, I would say this is very much a patient-by-patient and case-by-case decision that has to be made. I think it's hard to be dogmatic. I mean, I think there are cases that are high risk where some of these mutations are more sensitizing, where I have actually, applied. And we have to remember, it's off-label. You also have to tell the patient, we're not sure we'll get insurance approval even if we want to use it. But I think it is a discussion that's worth having, and sometimes even in tumor board, we discuss that.
And also, we're going to hear the LAURA data at the plenary session on Sunday. Any thoughts about osimertinib after chemoradiation? Are you guys already doing it or waiting for the data with LAURA? Josh?
Yeah, I mean, I'm already doing it. And, if we're going to treat patients with a biomarker-driven strategy, you can't give an EGFR mutant patient, adjuvant or consolidation durvalumab. So in the stage 3B, 3C patient population, I, for some time now, have been using, off-label adjuvant, osimertinib or consolidation osimertinib. So we're really excited to see the data. We saw the press release. That is lifelong osimertinib. So it'll be interesting to see what happens in clinical practice.
Want to get to the ctDNA, so.
The 2024 ASCO meeting is a historic one for lung cancer with 3 plenary presentations. But Dr. Herbst revealed to me another data set that's going to be presented there that might have a huge impact on clinical practice immediately.
The ADAURA investigators are presenting an abstract in the oral lung session, which will show some of the results looking at cell-free DNA. And what will be shown is that, we can measure this post-resection and follow this in patients, and there'll be a correlation with outcome. So my question is, realizing we haven't seen all those data yet, how will this affect your current practice? Are any of you using some sort of cell-free DNA assay in your patients in the adjuvant setting? Are you using it in patients post-chemoradiation? If so, what assay? How frequently? Is it insured? Is it paid for? These are all questions that I think are very relevant to current practice, and people will be calling you on Tuesday when you get home, given the data that we're hearing at this ASCO meeting.
All right, Joel, you brought it up. Are you using it?
Yeah. So first, when we talk about cell-free DNA, not all assays are created equally. And I think it's really important to have a tumor-informed assay, at least as of right now. I mean, we know that these patients have, by definition, EGFR mutant lung cancer, and we should be able to see those mutations floating around. But tumors have a lot of other mutations, too. And the more that you can do whole exome sequencing of the primary tumor, the more other mutations you can find, and the higher the reliability at a very, very low copy number. 1 in a million copies of DNA in the blood can be detected. So these tests are very, very different than the tests that we use in the metastatic setting, where we're just looking at big, bulky tumors that are shedding DNA that shouldn't be around. So first, the right assay. And second, there are companies that are allowing insurance to pay for post-surgically resected tumors to do whole exome and then do basically very custom primer-directed periodic sequencing over time and following MRD. So I've been sending those increasingly, and I'm curious if anybody else has.
Corey?
I still think it's a research tool for the time being, certainly for clinicians out in the real world as opposed to academia. Stay tuned for the results that we'll see. I think such assays really need to further inform therapeutic decision-making. So if we're suddenly seeing the reappearance of cell-free DNA that had disappeared or was never there to begin with, then what do? Do you start treatment again? Do you intensify the treatment? We need clinical trials to really address how useful it is as a surveillance tool and whether interventions based on that make any difference in outcome.
Right, and those studies are ongoing, and maybe you'll talk about some. Corey?
Well, thank you. Thanks for inviting me for this. So I get to do the lead-off talk. We'll talk about contemporary care for patients with non-metastatic EGFR mutation positive. First, talk about the incidence of EGFR mutations, then an update on ADAURA, some of the other trials that address the questions that John and Roy raised, and then finally, the LAURA trial, which will be a plenary paper this weekend. So here's the relative incidence in light blue. I think that 30% figure is a bit high, maybe not for the West Coast or for institutions like yours, Helena, where you see a lot of EGFR mutation patients. But for the general world, it's probably closer to 20%. You get into tobacco-producing states like Kentucky and the Carolinas, it's probably down to 10 to 15%. Go to East Asia, it's probably 40% or higher. Nevertheless, in early stage, we seem to find EGFR a bit less. And these are studies, retrospective and prospective analyses that are based on huge numbers of patients. ADAURA is not the first trial to look at adjuvant EGFR TKI in the resected setting. There have been several other trials in resected EGFR mutation positive non-small cell, none of which showed a survival advantage, and only 2 of which even showed a PFS advantage, which obviously did not translate into OS. This is the original data as presented by Roy at the plenary session 4 years ago now. A wide separation in the curves, really occurring quite early for DFS between 6 and 12 months. You see a hazard ratio here that's astounding and unprecedented at 0.20, favoring osimertinib over placebo. Remember, chemo here was optional, although generally used in N1 and N2 disease. And at the same time, and then later updated, we see CNS protection. Again, statistically significant, a hazard ratio of 0.24, with separation occurring at about a year to 18 months, again favoring the osimertinib group. This was the final analysis and the commentary by Ben Solomon. And here we see something a bit disturbing. After 3 years, which was the duration of therapy, start seeing a drop-off with heightened recurrences. And might this translate into a survival or lack of survival benefit? But the curves that were shown are quite promising. Not just 3, but 4 and 5 years, we're seeing a 10% absolute improvement in overall survival for the entire intent to treat group and then for the stage 2 and 3A patients. I call these fishtail survival curves because you see further separation over time as opposed to banana-shaped OS curves where they bulge at the median and then they join together later on. The question was asked, does it make a difference whether you get adjuvant chemo? And the answer is no. The hazard ratios here are virtually identical, 0.49 for those getting adjuvant chemo and 0.47 for those who did not. So without question, a groundbreaking trial in lung cancer showing the role for targeted therapies and translating that from advanced disease to the curative setting. There are some criticisms. Again, only 39% of those with progression on the control arm actually crossed over to osimertinib. Ongoing questions about the duration of treatment. 3 years was empiric. Why not go longer or shorter, perhaps? Role in atypical sensitizing EGFR mutations, which Josh raised, or even earlier stage resected non-small cell, as Roy raised. And I think it really underscores the absolute necessity of obtaining routine molecular testing in early stage disease. This is ADORA 2. Roy alluded to that. This is earlier stage 1A2 to 1A3, basically 1 to 3 centimeters. As I mentioned earlier, outside of this clinical trial, I have not routinely given OC to super early stage patients. Other than that, the trial design is virtually identical. 3 years of OC versus placebo, targeted accrual 380 patients. First patient in was about 2.5 years ago, and I think the trial is still ongoing. And then the target trial, which is actually a phase 2 trial, looking at a longer duration, 5 years. 150 patients slated for those with common sensitizing mutations. And again, addressing Josh's concern, a separate cohort, 30 patients with uncommon but still sensitive mutations like 719X and 861Q. So no control arm here, but since we've already seen benefit in phase 3, I think a control here would be probably unethical. The question was raised whether it's worth giving osimertinib up front prior to resection. NeoAdora will address that. Again, big trial targeting 350 patients. This is down the home stretch. And one of your colleagues, I believe, is the PI, Jamie Schaff, looking at OC alone for 9 weeks or a little bit more versus OC combined with chemo, pemetrexed and either carbocis, or just chemotherapy alone in the pre-op setting. So I think important data will come from that. MPR and path CRs are the two of the primary endpoints. And then finally, Pacific 4 actually started out as a trial for early stage patients treated with SBRT, looking at durva versus placebo, but it was later amended for those with EGFR mutations as a separate phase 2 cohort who were assigned automatically to OC after the completion of SBRT. No control arm in that group. And again, this trial is ongoing. It'll probably be a couple years. So we segue now into locally advanced disease. You're all familiar with Pacific, 2-to-1 randomization of durva versus placebo, and folks who had finished chemoradiation had no evidence of progression. 10% absolute improvement in 5-year survival. Again, unprecedented results. This trial actually allowed folks with EGFR mutation. It was a tiny subset, about 5% overall. And if you look at the table on the right, no obvious benefit. PFS for the placebo is 10.9 months versus 11.2 months for Durva in this group with an HR of 0.91, and survival was virtually identical as well. Again, only 35 patients, can't draw very many conclusions, but in this population, obviously no PFS or OS advantage. Their empiric use previously, in the absence of clear-cut oncogenic drivers, actually not only failed to yield an OS benefit, actually resulted in a survival decrement. The old SWOG 0023 trial looked at gefitinib in this setting after chemoradiation versus placebo, and placebo did better. And then finally, a retrospective analysis in patients with EGFR mutation positive locally advanced receiving an appropriate TKI actually these folks do fare better than those getting a checkpoint inhibitor, just observation. This was presented last year at World Lung by Amin Nasser. It's a consortium effort, 24 separate institutions with well over 150 patients, looking at outcomes for those who got OC alone, Durva as consolidation observation. All three arms were essentially well balanced with respect to age, gender, race, PD-L1 levels, smoking status, and stage. If we look at the disease-free survival, we actually see a benefit, a p-value of less than 0.001 for OC compared to either observation or consolidated Durva. That has not translated into survival benefit. Again, very small numbers, very early follow-up, and more than 2/3 of patients on either observation or Durva crossing over to a TKI. And as we've seen already in ADAURA, a CNS protection, lower CNS relapse rates in that group. So the fourth argument in favor of looking at osimertinib after chemoradiation locally advanced really comes from the findings of both FLORA and ADAURA. If it's positive in metastatic disease and positive in early stage disease, it's bound to be positive in locally advanced. And here's the study, the LAURA study design, which will be unveiled in great detail this weekend. 2-to-1 randomization for OC versus placebo. The OC keeps on going. I don't believe there's a time cutoff. John had raised the question of 3 years, but here it's indefinite. Patients are stratified by whether they got concurrent or sequential chemoradiation by stage and whether they were accrued in China or other parts of the world. I have gone on record as saying I will eat my Yankee hat if this study is negative. My Yankee hat is quite safe. Here's the press release, all we know officially from 2 months ago, a statistically significant and highly clinically meaningful improvement in progression-free survival in patients with locally advanced EGFR positive non-small cell, and OS showing a favorable trend. Again, very immature data, but I imagine all will be unveiled, and by Monday or Tuesday, we will routinely be giving osimertinib in folks who finished chemoradiation and have an EGFR mutation.
All right. So now we move on to metastatic disease.
It seems like the decision for first-line therapy of metastatic EGFR mutant disease has transformed overnight from the commonly used option of osimertinib monotherapy to the addition of chemotherapy or the use of the combination of amivantamab and lazertinib. Here's some questions related to this new dilemma.
In 2024, we now have the choice of osimertinib as a frontline drug, but we also have FLAURA2, osimertinib plus chemotherapy. We saw that now the survival hazard ratio, not quite significant, is 0.75. So the question I have is, how do you decide to use osimertinib alone or osimertinib with chemotherapy as per the FLAURA2 regimen? The other question I have for the panel is, what about the whole new approach of the dual c-Met EGFR antibody amivantamab in combination with lazertinib? We now know that from the Mariposa trial presented at ASCO last year, a positive result. Still waiting the survival from that, but clearly much improved progression-free survival, as high as 22 months, the median progression-free survival. So the question is, regulatory approval aside, is that something that one would use? Amivantamab is new to us, has some unique toxicities, but where does that fit into the whole discussion? I've been in the audience at all the presentations, the different meetings. I've seen that there are different characteristics of patients, burden of disease, brain mets, early fusion, and so forth. Is there one characteristic or one setting where one of these regimens might have an edge over the other? This is something that we discuss here at Yale often, and I think it would be a great topic to discuss as a group now.
Because amivantamab works by a different mechanism than our tyrosine kinase inhibitors, being a bispecific antibody, it raises the question, first of all, do you have any ideas of who is more likely to benefit? Do you have any markers to help you select who gets it? And secondly, any thoughts so far about mechanisms of resistance? There hasn't been a lot described about mechanisms of resistance. So, right now we're still in the midst of trying to formulate a strategy of what we do next after amivantamab progression.
All right, this is a big question, and we have a lot of options now. And I think one of the questions is the default osimertinib, and do we escalate, or is the default now more aggressive therapy and we de-escalate? Jonathan, any thoughts about what do you use now for a first-line patient metastatic that comes to your clinic?
So absolutely, the discussion's just getting longer and longer with patients. I would consider that my default is osimertinib, and then I also say with patients, there is new data that escalating intensity with chemotherapy, a big difference in your quality of life and schedule of life, but with a clear PFS benefit, possible overall survival benefit, and really the tantalizing evidence about CNS disease. So a patient that wants to be aggressive and has CNS disease, I would certainly offer it, and I might lean that way.
So in this exactly like you said, Jonathan, a younger patient in her 40s with children, EGFR mutation with brain metastases, so aggressive disease. Zofia, what would you do for?
Yeah, I think that they're both reasonable options, but I will say I think for a patient like this, there would certainly be a strong appeal to consider a combination approach up front. I think for several reasons. One, I do find the data for intracranial metastases in FLAURA2 compelling. We clearly saw deeper responses. We saw more complete intracranial responses, and I think that's important. I think the burden of CNS metastases does matter. If they're very small punctate lesions that you think osimertinib will likely treat, that may not be as strong of an indication, but someone with a high disease burden and CNS metastases, I think so. We also know that not all of these patients, as much as we hate to admit it, make it to subsequent therapy. And so there's also the appeal of giving them, multiple effective agents up front, knowing that will at least extend their PFS and perhaps give them access to therapies that they could not see. But I agree, it's a discussion with each patient, and these are not easy decisions that we're making in the clinic right now.
Josh?
Yeah, I agree. This discussion has become, very long. I block an hour and a half now to have it. Look, 18.9 months median progression-free survival for a young patient, a 40-year-old patient with young children, brain metastasis is not sufficient, and I think we need to do more. The addition of chemo is helpful, but I don't think there's going to be true overall survival there. I think amivantamab and lazertinib has the potential to build upon that. Yes, there are toxicities. We saw two very exciting presentations today that I'm sure we'll hear about, some of the subset analyses looking at high-risk features like P53, brain metastasis, positive or not clearing the ctDNA. It seems that, in that Mariposa trial, amivantamab and lazertinib benefited all those high-risk subgroups over, osimertinib alone. And I think another interesting point is the toxicity and how do we mitigate that. We saw some data today on the subcutaneous formulation over the IV formulation, and we saw a trend towards positive survival in an exploratory analysis. So I'm actually pretty excited about that population.
Corey?
I think the data presented today for sub-Q is actually one of the, hopefully a game changer, certainly for amivantamab. The apparent OS benefit was a surprise to me. Again, this was in the advanced disease setting. Far less toxicity. Infusion reactions were reduced 5-fold, major reduction in thromboembolic phenomena. The drug just became safer and a hell of a lot easier to give. 5 minutes as opposed to 5 hours. So a lot of my concerns about amivantamab, I think, will be addressed by the transition from IV to sub-Q. Hopefully it will happen quickly. We're still contending with other toxicities, such as edema, fluid retention, and of course, sometimes quite severe rash when you're using double EGFR inhibition. I personally, for the high-risk patients, and we still need to define those better, would have equipoise comparing amilaz to OC chemo. I think the results are very, very similar, and if such a trial existed in a patient with fulminant presentation, I would happily put that patient on such a trial.
So people brought up risk factors, Joel. So do you use any of these, P53, ctDNA, in your practice today?
Yeah, so we saw those data just a couple of hours ago. Out of all those risk factors, the hazard ratios look very similar as the magnitude of benefit. So there were a couple of groups, potentially liver metastases, that had slightly lower hazard ratios, suggesting a little bit more benefit from the AMI-LAS. And in addition, the TP53, when you look, because P53 is in about 50% of EGFR mutant lung cancers, and has always bugged me as something that instead of that almost 19-month PFS, the PFS is closer to 12 months. So if it's there in half of patients, the hazard ratio is, I think, 0.65 for TP53 mutant and 0.75 for TP53 wild type. And that might be a distinguishing factor where there's kind of a separation and a predictive, not just a prognostic biomarker.
And I think, Corey mentioned we have Emi laser, amivantamab lazertinib, we have FLAURA2, the chemo osimertinib. Is there any way that you all are right now, or if both were available, that you would use to distinguish between the two? Who wants to take this?
The question for patients is which side effects do you really, really not want, right? Do you really, really not want to come and get an infusion every 3 weeks? Maybe a sub-Q injection will be available right around the corner. Do you really, really not want a pustular rash, and lower extremity edema? At the same time, are you comfortable with maybe a slightly shorter progression-free survival, knowing that we're saving all of these highly effective options for later line therapy? AMI is very effective across all lines of therapy from what we've seen in these common mutation types.
The sequencing question really is a big one. Jonathan, any other comments?
I think right now, starting with chemo OC and then going to AMI combination in second line is looking appealing. I think a lot of my mindset is based on the experience of giving IV amivantamab, and it could be really changed quite significantly with a change of formulation.
Absolutely. All right. Take it away.
So thank you very much. I'm really so pleased to be part of this panel. I've listened to Research to Practice for many years, and this is my first time on this side of the event. I'm at UCLA, where I lead the clinical trials group in lung cancer. And I was generously given this topic that's really in flux, controversial, and most importantly, giving our patients new options. So we'll review this by talking about the 3 trials that have been mentioned. Ever since the IPASS trial 18 years ago or so, we've been using first-line EGFR TKI, but the FLAURA trial established osimertinib as the optimum first-line agent. FLAURA2 added back chemotherapy and showed a progression-free survival benefit and possibly an OS benefit over OC alone. And MARIPOSA chose the similar lazertinib agent added to amivantamab versus osimertinib and also showed a PFS benefit. So the FLAURA trial used the osimertinib, which we're all familiar with, CNS penetrant, highly active, and T790M active agent versus a first-generation drug, gefitinib or erlotinib. About 550 patients were randomized 1-to-1. And you're about 5 times more likely to still be on treatment at the end of this analysis if you're on the OC arm. The landmark analysis shows that about 20% more likely at 1, 2, or 3 years to still be doing well on osimertinib. And survival was improved by about 10% for each of those time points. Brain met positive patients also had about a 20% benefit at each time point. One of the things that really, I think, accelerated the uptake of osimertinib use is its good tolerability. There's a small improvement in grade 3 adverse event rate, but rash is dramatically decreased with osimertinib, so a better patient experience. PFS shows that the hazard ratio for progression or death was reduced by more than 50% really early, convincingly, and the lines stay separated. The overall survival benefit, also important, 20% improvement in the risk for death. And nevertheless, both lines are coming down pretty quickly at the end. And as many have said, these numbers are not sufficient for our patients. So what do we do to improve the benefit here? FLAURA2 added back chemotherapy, platinum, pemetrexed, with osimertinib versus osimertinib alone. The addition improved overall response rate, duration of response, and progression-free survival to about 25.5 months. Hazard ratio was 0.62. Now, when we look at the landmark survival, we're about 10% better than we were with osimertinib alone. The benefits here seen on the progression-free survival. In the overall group, again, convincingly different. But what really stood out and was mentioned before was the benefit in brain met positive patients. The lines separate further. Very interesting. I don't think anyone would have necessarily predicted this. In fact, you may have thought the opposite. But we really are seeing across this trial with multiple different cuts and analyses that this does seem to be a real finding. Some of the other subgroups, both Exon 19 and L858R, had similar benefit from the addition of chemo. Again, perhaps surprisingly, it was the ECOG-1 patients who had maybe more benefit than ECOG-0, and the brain met patients did better. This is from the package insert, which I found really interesting. Many of our patients do well with osimertinib, but you were twice as likely, almost twice as likely to be progression-free in the brain with this combination than if you were only getting OC alone. Really, I think a meaningful difference there. So, are we going to use it? Are patients going to use it? There's a few important points here. I think the overall survival is important. This was at the first analysis with only 27% data maturity. But in February, this combination was given FDA approval. And around that time, AstraZeneca released some updated analysis. So at this time, with 41% data maturity, the curves do seem to, or the medians do seem to be distinguishing themselves. The confidence interval is just below 1, but because of the statistical setup, that was not significant in the analysis. Next on the adverse events, certainly higher hematologic toxicity, higher grade 3 events, as would be expected. But I think what doesn't come out in the numbers is the different patient experience. That when we're treating someone with osimertinib TKI alone, I hope that they're living their lives and not thinking about having cancer 24/7. It gets really hard to do when you're getting chemotherapy every 3 weeks. The time in the office, the time in the infusion center, I think is meaningful. So the last trial I wanted to talk about was another attempt to bring IV therapy in with a TKI to improve outcomes. They used lazertinib, a similar third-generation CNS-penetrant EGFR TKI, and added amivantamab, the bispecific antibody we talked about, right now only approved for EGFR exon 20. Infusion-related reactions are really one of the most important toxicities to know about as a physician and tell your nurses and tell the patient. 2/3 of patients do get an infusion-related reaction, but usually only with the first 1 or 2 doses, so there's a split dosing and a loading weekly dose for the first cycle. This trial, with the primary endpoint of comparing the AMI-LAZ arm to osimertinib, also included a single-agent LAZ and OC arm for the contribution of components analysis. Amivantamab, I think it was brought up by John, what's its mechanism of action? I think so much is yet to be learned and explained. There's certainly a ligand blocking activity, just like other antibodies, but receptor internalization and degradation does seem to be perhaps particularly important. There is some preclinical data that you get cross-linked rafts of receptors that maybe put some physical stress even on the cell membrane and leads to internalization and degradation. You also do get antibody-directed macrophage activity and cellular cytotoxicity. This is from the Chrysalis trial, the phase 1 trial, which had a cohort E, an expansion in this population of first-line untreated EGFR canonical mutation-positive patients. They all responded. Duration of response was promising, leading to this phase 3 trial of Mariposa. You see in the green the lazertinib arm and gray the osimertinib arm overlapping, but what's really important is the combination of the study arm AMI-LAZ with osimertinib. Hazard ratio is 0.70, but I do think convincingly different and separating and remaining separated. Forest plot, quite small, so the differences might be minimized, but mostly the hazard ratios do hold together. And there is small improvements in the response rate and complete response rate, but primarily I think it's in the duration of response that you get the benefit. The interim overall survival's perhaps a suggestion of separation, but immature data. And again, we get to the issue of toxicity and tolerability. So there were the expected toxicities. We talked about the rash, sometimes quite significant on combination therapy. There can be some diarrhea, which also can be meaningful. There are MET-related toxicities, peripheral edema, and hypoalbuminemia. But what I think surprised many was the VTEs event. About a third of patients, or a little more, got VTE on the trial and on that Amy-Laz arm, and that led to the recommendation for ongoing trials, prophylactic anticoagulation for the first 4 months, and that was described earlier this afternoon with some clear benefit to taking that approach. So I think in the end, toxicities and quality of life may determine for each particular patient whether the benefit is worth the toxicities. And I just to highlight, as we've been speaking about a couple talks, actually, in addition to this biomarker talk, the sub-Q delivery talk also, I think, will be practice changing when we work it all out and think about it further.
We're getting some great audience questions, so I think we have time for one or two. One question is for a young lady, 40 years old, with oligometastatic disease, a single rib met, a single brain met, and a lung primary. How would you approach them in the setting of the different options that we have?
So that was also addressed this afternoon, a oligometastatic radiation approach, and perhaps that ends up with less enthusiasm than we had previously thought. I think that we are starting with systemic therapy and considering consolidation. The brain met specifics will depend on whether there might be a need for upfront therapy there, but usually we're getting benefits from systemic therapy. As I said, my standard is still osimertinib for most patients. There are some patients where I'm escalating. In fact, I was going to say the only patient that has off of trial agreed to escalate was an 80-year-old woman with brain metastases. And so I think you can tell from the subgroup analysis, it's a little hard to predict. I certainly wouldn't do that if her performance status was low, but she was well enough to get chemotherapy, and so we're going to start soon.
Patient-directed care. One other quick question for Zofia. So a patient that started on EGFR L858R, started on osimertinib, great systemic control, new leptomeningeal disease. What do you do?
Really difficult question. Really, I think a dreaded one in the clinic, but unfortunately it comes up quite a lot. And the truth is, unfortunately, the kind of CNS penetrant options for leptomeningeal disease that comes up on osimertinib are quite challenging. We know that for a patient who's newly diagnosed with LMD, osimertinib can have good benefit. In the setting of LMD that develops on osimertinib, I think our options are a few. That we can consider radiation therapy, although we know that the benefit of that and the toxicities of that can be challenging. We can consider whole brain radiation, cranial-spinal irradiation. Those can be difficult. We can consider chemotherapy, and I would say often that's actually something that we reach for out of a lack of better options more than a true enthusiasm for it, I would say. And there is some CNS penetration with pemetrexed-based chemotherapy. And so a lot of times for those patients, that's something I will consider. The last option is dose escalation of osimertinib, going from 80 to 160 milligrams. In a retrospective analysis, we showed that there was maybe some durability of intracranial disease control range in the range of about 6 months with that. But, I think that's also not a great option. So these are patients that we need better options. I think we'll actually see some data from your group for amivantamab lazertinib for patients with LMD, and I look forward to that. But right now, I think of the options, I'd probably lean towards chemotherapy, but perhaps have a conversation with the radiation oncologist as well.
Great. Now moving on to antibody-drug conjugates.
In addition to the use of ADCs in patients with disease progression on osimertinib, a number of other strategies are being investigated, including approaches that involve the use of biomarker assessment.
Certainly the HER3 ADC is one that has been in many clinical trials, and many of our sites have had that. So now as that moves even further along, how relevant is that? Is that something that should be used? The one thing I've noticed, however, in the early trials, that even though they might have responded in their systemic disease when you gave the HER3 ADC, that the brain was a site of recurrence. So I think the trials that are looking at these drugs now in combination with osimertinib are going to be very exciting and important to follow. Should you test for HER3 expression? We certainly know that the whole EGFR axis, HER1, 2, 3, and 4, and the dimerization, that does affect signaling in this pathway. Is this the light at the end of the tunnel that we've been looking for? It's been a long tunnel. What do you all think?
All right, I think we'll get to the ADCs, but I think a question that is relevant to a lot of clinicians is, after somebody progresses on first-line osimertinib, do you repeat biomarker testing, either a liquid biopsy or tumor tissue biopsy, to identify mechanisms of resistance? Corey?
Absolutely. Always liquid tissue when it's accessible. Folks who have fulminant progression, you really need the tissue to rule out small cell transformation. It's my impression I'm seeing this more with OC than I saw with the first generation TKIs. So more indolent, smoldering progression, probably less forced there to do a repeat biopsy, although ideally I want to really know the landscape, the new molecular landscape of that patient. And we have so many options, really depending on the nature of the potentially new drivers that appear. So this is an area that's ripe for further investigation. And I think, above all, a one-size-fits-all approach does not apply.
Yeah, I would just add that although acquired mechanisms of resistance are rare, our group looked at that and we found that survival was better if patients received mechanism of resistance-directed therapy. So I totally agree, Corey. Next question. Assuming you had access to amivantamab chemotherapy, so MARIPOSA-2, and patritumab deruxtecan, how would you likely sequence them for patients with disease progression on single-agent osimertinib? I think this will be a very real question, hopefully soon. Josh?
This is a great question, and I think these combinations have unique toxicity profiles. And here we're moving away from a chemotherapy-free or sparing regimen. Both of these, patritumab deruxtecan has a topo payload. Chemotherapy is carboplatin pemetrexed. I personally feel more comfortable, confident. I know those chemotherapeutic agents and I know how to manage them well. Deruxtecan is more of a difficult payload in my experience. I mean, patritumab data looks good, but I would probably save that for the third-line setting. Curious what others would do.
Joel?
Yeah, I haven't used patritumab yet, and looking forward to re-reviewing the data together. But from what I can tell, amivantamab looks like a very effective drug. We're even talking about it in the first-line setting. It overcomes two of the most common mechanisms of direct resistance, whether we see them or not, the EGFR amplification and the MET-directed therapy too. So I think using amivantamab earlier to try and head off resistance, whether we see it or not in the liquid biopsy or the tissue biopsy, I think all of our biopsies really underestimate the tumor heterogeneity and the fact that multiple mechanisms can be going on. So I think, at least from what I know so far, patritumab looks like it'll probably be following AMI, chemo, and OC, or laser.
Zofia?
I was just going to add, I think one important point that comes up a lot in clinic is patients who have both systemic and intracranial progression. And I thought that was a surprising but really important data point from MARIPOSA-2, which was the study that looked at chemotherapy plus amivantamab. We saw that intracranial PFS looked to be improved with the addition of amivantamab to chemotherapy. Again, going along the theme of things that were maybe a little bit surprising to see, not something we were necessarily expecting with amivantamab, but I think that is compelling. And a lot of these patients do have both systemic and intracranial progression, and I think it gives us, a reason to potentially reach for that combination there.
I think it's surprising with both amivantamab and patritumab that these bulky, what we thought were bulky, antibodies and ADCs actually have decent brain penetration. And if patients are responding systemically, they often respond, intracranially as well. All right.
I've been querying Drs. Haymock and Herbst since the beginning of targeted therapy and then immunotherapy in lung cancer, and I always know anytime I sit down with them, I'm going to hear something I don't expect. And of course, Dr. Haymock came out with a really interesting case that led to a discussion of another historic advance in lung cancer that occurred just before the ASCO meeting.
I've got a 51-year-old gentleman of Hispanic origin who presented with metastatic lung adenocarcinoma, He was EGFR mutant positive with exon 19 deletion. He had some bony metastases, but a good performance status. We treated it with osimertinib. He had an excellent initial response, but then he progressed in the pancreas. We biopsied the pancreas, and he turned out to have small cell transformation. At the time, there was also some evidence of leptomeningeal disease. So the question is, what would you treat the patient with in this setting? And if you are giving platinum doublet chemotherapy, what do you combine with it? So when patients have transformation to small cell lung cancer, we're faced with the question of, do we switch over to small cell therapy or do we keep the TKI going? And we don't really have good data in the setting. So the question to the people on the panel is, what do you do in this case for small cell transformation? What therapies do you give? And what do you combine with platinum doublet? And then when that fails, where do you go from there?
I'm all excited about tarlatamab. You think it'll work here?
I'd say probably the most exciting advance in the field of small cell lung cancer since the approval of immunotherapy, and arguably even more exciting than the approval of immunotherapy. This is the first bispecific approved for small cell. And the exciting thing not only is the high response rates, but there really are a significant number of patients that are getting long-term durable benefit from this regimen. So I'm very excited to start using this routinely.
Has tarlatamab ever been used in transformed small cell?
That's our knowledge, but we know they do express DLL3. We've actually been looking at that. Lung cancer docs don't have a lot of experience managing cytokine release syndrome and managing these sorts of therapies. The same go for the CAR Ts. At our institution, the lymphoma docs and the leukemia docs give this all the time. They've got a whole group devoted to managing toxicity. So the question for everybody, are you all going to be giving the bites yourselves? Do you have doctors in your hospital, or are you going to set up special groups to manage CRS, or how are we all going to handle this? Is this just going to be a learning opportunity for the field that we'll learn to manage this ourselves?
All right, John asked us a lot of questions. First to say, I agree with Corey. I think with osimertinib, we are seeing more transformation. I think with a better on-target inhibitor, we're seeing more off-target resistance, which includes histologic transformation. So I think first, how do you guys, patient transforms with small cell transformation, what's first-line treatment for you?
I still resort to etoposide and platinum, usually carbo. I will generally continue the osimertinib, particularly if they had CNS disease that's come under good control. I often find that it's a mix and match. There's still some disease that's quite sensitive to the TKI, and then, of course, new disease that fulminant and histologically small cell. Second line, I've used lurbinectin in this setting. Frankly, the response rates are no better or no worse than I've seen in de novo small cell. And I would have, I've certainly considered tarlatamab, maybe even second line, certainly by third line. It is labor intensive. We're not used to managing these toxicities as a group. Certainly the community is not. It at least initially requires hospitalization. So there are a lot of caveats that are attached to this new and very promising agent. But still the specter of long-term survival, something that Lurbi and most other treatments, certainly chemo-based treatments, haven't offered.
Yep, challenging, but I think we'll figure it out. Anyone could use EP with IO for small cell transformation, or is the panel in agreement about the osimertinib?
I would say I try to use osimertinib. I will say I've had some trouble with myelosuppression with the combination of platinum etoposide with osimertinib. So in those patients where I've tried to continue it, I watch the counts quite closely, and there have been times when I've actually had to stop the osimertinib. But if you think about, giving platinum etoposide, you're really in the situation giving it for 4 cycles, and then if you're not giving immunotherapy, I've then reintroduced the osimertinib in a maintenance phase. So I think both are reasonable, but you do have to watch the myelosuppression a bit.
We have a poster on Monday with combining EP with osimertinib as prevention, so you can look at that. Joel, quick comment.
Yeah, I've had, I feel like 5 patients transform EGFR to small cell. Sometimes it's very localized, and I'll stop the OC, I'll give chemoradiation, just like we do for small cell lung cancer, and try to kill the resistant clone. But also, on the other hand, I had a patient with on adjuvant OC and got a ton of brain mets, big cystic brain mets 6 months into adjuvant OC, and I sent them to neurosurgery and said something weird is going on, and that was small cell. Yeah. In which case I'm like, do I do whole brain radiation, right? Yeah. So I generally, focus, try to kill the small cell clone, and often it can be localized, and then you can go back to the controlling the other lung cancer.
I would just say, last comment, I think because of the heterogeneity, sometimes taxanes can be helpful too, because they do straddle the adenocarcinoma small cell effectiveness. All right. moving on to antibody-drug conjugates. So I'll discuss the rationale and emerging role of ADCs in the management of EGFR mutant non-small cell lung cancer. So we'll go over HER3 and the different studies with patritumab deruxtecan, HER3-DXd, and then we'll talk about TROP2 ADCs, in particular datopotamab deruxtecan. So why HER3? So, I think we are hearing a lot about HER3 in the context of EGFR mutant lung cancer. So going back to biology, if you remember, both EGFR and HER3 are part of the HER family of proteins. So HER3 heterodimerizes with EGFR as well as HER2, and that heterodimerization leads to downstream oncogenic signaling. So there's a clear link and association with HER3 and EGFR. HER3 expression in non-small cell lung cancer is really ubiquitous, where we do see pretty diffuse expression, and in particular in EGFR mutant lung cancer, where almost all EGFR mutant lung cancers express HER3. And I think importantly, with drug development and what we're choosing for these ADCs, HER3 is a poor prognostic biomarker. So the presence of HER3 on the cell surface of tumors predicts shorter survival, quicker recurrences for early stage disease. And so we're selecting something that leads to high risk. So patritumab deruxtecan. So this is our first talk about antibody-drug conjugates, which we know are approved in breast cancer and urothelial cancer already. But these are drugs with three components. They have a monoclonal antibody, they have a chemotherapy payload, and a cleavable linker as the different parts that are somewhat interchangeable for the different drugs. And so HER3-DXd, patritumab deruxtecan, was the first in-class HER3 ADC. The phase 1 study looked at patients with metastatic EGFR mutant lung cancer who'd progressed on prior EGFR TKI therapy and looked at escalating doses of HER3-DXd. And in that original phase 1, you can see the waterfall plot on the bottom right, where the vast majority of patients did have clinical benefit with tumor shrinkage. And too hard to see here, but you could refer to the paper. One thing we did say is resistance is heterogeneous, but it did look like if patients had either on-target resistance, like a C797S acquired mutation, or off-target resistance, like MET amplification or an acquired, say, BRAF or ALK fusion, these drugs, since they do essentially contain chemotherapy, did seem to be effective for different mechanisms of resistance. And then the progression-free survival on that phase 1 study was 8.2 months. So a successful phase 1 leads to a phase 2 study, and that's the Helena Lung-01 study. This was a similar patient population, EGFR mutant lung cancer, progression on, here they needed to have progression on an EGFR TKI. Almost all had prior osimertinib. And they also needed to have prior platinum-based chemotherapy, so progression on those two lines. And asymptomatic but untreated brain metastases were allowed. And initially, there was two different regimens, an up-titration regimen and a fixed dose at 5.6 mg per kg. And after a short period of enrollment, the 5.6 mg per kg was chosen as the recommended phase 2 dose. You can see 225 patients were enrolled. I think similar or mirroring this patient population, 51% had brain metastases, and again, almost all had prior third-generation TKI. Primary endpoint of the study was response. And so here you see the data, efficacy data. So the overall response rate was approximately 30%, median PFS 5.5 months, survival about a year. When you look at the forest plot to look at subgroups, it did look like all subgroups really did seem to have benefit. And I think a really important question for these ADCs is there a biomarker? And so archival tissue was collected on the study, and HER3 IHC was assessed. But you can see from the figure on the bottom left that really there did not seem to be a separation of HER3 expression by H-score based on response, stable disease, or non-response. And so what's been challenging with ADC development is really, or for some of these ADCs, is that the degree of expression really doesn't appear to correlate with efficacy. And maybe that's because you need very little of this cell surface protein for these ADCs to be effective. And so this is the waterfall plot from the Helena Lung-01 study again. Majority of patients did have disease shrinkage, and I think importantly, response and efficacy in patients with different mechanisms of resistance within their cancer. And then last year, Dr. Johnson presented the intracranial data, which showed in patients that had active brain metastases that were not previously radiated, so measurable disease, the response rate in the CNS was quite similar to the systemic response, so 33.3%. So again, these antibodies and ADCs do appear to be able to penetrate the CNS. And that leads us to the phase 3 confirmatory study. So this is patients moving one line up. So patients that, again, have the common sensitizing mutations. They were allowed to have received prior EGFR TKI, but no prior chemotherapy. And again, stable brain metastases were permitted, and patients are being randomized 1-to-1 to HER3-DXd in the second line or third line setting after 2 TKIs versus platinum-based chemotherapy. And the primary endpoint here is progression-free survival. And so this study began about 2 years ago and is close to enrollment, and we're awaiting the readout. So moving on to TROP2. So TROP2 is another cell surface protein that is relevant in a lot of different cancers, including non-small cell lung cancer. Its activation leads to, again, oncogenic downstream signaling that is important for metastases and cell survival and proliferation. And again, similar to the HER3 story, widely expressed in non-small cell lung cancer and is a poor prognostic marker. So presence of high TROP2 expression leads to shorter survival. And so datopotamab deruxtecan is one of a few TROP2 ADCs that are in development, very similar to both trastuzumab deruxtecan and patritumab deruxtecan, a different antibody, but a cleavable linker, and then the deruxtecan topoisomerase-based chemotherapy payload. And so we saw this data from the Tropion study looking at so the patients with non-small cell lung cancer that were previously pretreated, and patients were randomized to Dato-DXd versus docetaxel. And this study actually allowed squamous cell as well as adenocarcinoma, and did allow patients with actionable genomic alterations. And I think the data here, where Dato-DXd did statistically show an improvement over docetaxel, but only in the non-squamous arm. And I think one thing of interest here is in the non-squamous adenocarcinoma arm, there was a reasonable subset of patients that had actionable gene alterations. And so there was a question, is this driving the benefit in this population? And so that led us to the Tropion Lung 05 study. So this is a study of Dato-DXd that is focused in patients with metastatic non-small cell lung cancer, but with an actionable genomic alteration. And that was EGFR, ALK, ROS1, NTRK, BRAF, MET exon 14, or RET. And they received Dato-DXd, and you can see the breakdown of mutations there. And so we have seen the data here, and was just presented last year at ESMO, where you can see that the response rates were higher than in the sort of overall greater population, where when focusing on the EGFR mutant lung cancer population, the response rate was 43%, ALK a little bit lower, median PFS around 5.8 months as well. So I think another active ADC in the EGFR mutant lung cancer space. And then toxicity. So I think, these ADCs are a type of targeted chemotherapy is how I'd explain it to my patients. So we do see chemotherapy toxicities like alopecia, cytopenias, nausea, and that seems to be universal across ADCs. And then there are some unique toxicities. So the ADCs with the deruxtecan backbone do have a risk of ILD or pneumonitis that seems maybe higher with trastuzumab deruxtecan, lower, more like 5% with HER3-DXd and Dato-DXd. And then uniquely with Dato-DXd, you see mucositis, which can be quite bothersome and severe for some patients, and some ocular toxicity. So you can get toxicity from the payload, but also from the antibody. And so really, in summary, I think antibody-drug conjugates are here to stay. You're going to see more and more data on them at ASCO. I think HER3 and TROP2 are important cell surface proteins that are reasonable targets, both in non-small cell lung cancer at large, as well as in EGFR mutant lung cancer. So now we move on to strategies for later line metastatic disease with Dr. Sabari later.
The management of patients with initial response in the first-line metastatic setting to osimertinib, followed by disease progression, has been the subject of extensive investigation of a variety of treatment strategies, and Dr. Haymock has a series of questions about this common dilemma.
For patients who progress on osimertinib, the question is, do we need biomarkers to tailor our therapy? Because we like to think our therapies are getting more tailored, but we see a number of the studies that have come along actually are for broader populations. So question to the panel is, when you have a patient who progresses on osimertinib, do you do profiling? And if so, how does it impact your subsequent choice of therapy?
Well, we know that with osimertinib, the majority of patients, 70%, maybe more, will respond. The question is the development of resistance. So the question is, how do you treat that resistance? And is it treated differently if it occurs as a primary resistance early on, within the first few months versus a year or two later? Do you continue the osimertinib? Do you add chemotherapy as per the FLAURA2? Are there new novel combinations that one might try? What about amivantamab? What about, the Mariposa study? Is anything gleaned from that? These are all things that I think we probably all deal with in our practices on a rather routine basis.
We talked about some of this already. I think maybe let's go over those different scenarios. So for a patient that receives first-line osimertinib chemotherapy, and then after 3 years, perhaps after the pemetrexed is discontinued, what second-line therapy would someone consider? Josh?
Yeah, this is a great question. We're starting to see this happen in the clinical practice. So my first question is, the patient progress on therapy, off therapy, right? If it's off therapy, you might be sensitive and you want to resequence the patient. If they progressed on therapy, right, I would treat that patient as a recurrent metastatic disease patient, right? They're going to likely have resistance to osimertinib, and we have to define that. In our tumor boards, we're biopsying tissue-wise 100% of our patients. But in our real clinical practice, right, we're pretty much getting only 30%, 20%. Don't forget the high-risk transformations. If a patient is very symptomatic, you do need to get the biopsy. But liquid biopsy has been very helpful for us in defining heterogeneity. And I agree with you, Helena, based on their resistance mechanism or mutation, I think there are multiple different options. But as John said, a lot of the therapies that seem successful are more broad.
Zofia, do you want to comment on some of the mechanisms of resistance we do see and how we might treat them?
Yeah, I think, I very much agree with the remainder of the panel that I think whenever possible, tissue testing still remains the standard of care and is important, I think for two main reasons. The first is histologic transformation, which, when we look across the studies, can be seen in up to 15% of these patients. And while I agree it's certainly the biggest concern in patients with kind of more rapid disease progression, we've also had cases where it's more indolent progression, and we've been surprised to find small cell. I think an important factor to remember is patients who have baseline P53 and RB1 co-mutations are much, much higher, 43-fold higher risk of small cell transformation. So on that baseline NGS report, if you see the kind of triple threat of an EGFR mutation along with P53 and RB1, those patients really must have a biopsy to rule out transformation. So that's the first thing. That's immediately actionable in the sense that if you find that, as we talked about, you can put them on platinum etoposide chemotherapy. I think MET amplification is another one where potentially either on a clinical trial or even through the off-label use of a combination of an EGFR and MET inhibitor, you can potentially treat these patients in a targeted fashion. So MET amplification we usually test for either by next-generation sequencing. At our institution, we also do MET-FISH, but a lot of times it can be detected on regular NGS. And we also know that MET amplification is better detected on tissue biopsy than it is in plasma. It's more reliably detected. Those are the main things. Other things we can rarely see are acquired oncogene fusions, and for those, there are case reports you can find of combining, for example, if you have an acquired ALK fusion or ROS1, the relevant TKI with osimertinib. All of these things are potentially actionable. And when I talk to patients, I say this is something we need to do to rule out these options, but still we know that 50, 60% of these patients, even if you do a biopsy, those patients won't have targetable alteration. And there, I think, chemotherapy, really, I think thinking through this toolbox of options that we've talked through and thinking, okay, which ones have the patients had already and which ones have they not had yet? I think that's how more and more we're going to be thinking about it, and selecting what the next line should be.
What about squamous cell transformation? We've been seeing that a little bit. Jonathan, how would you treat someone that has that on biopsy?
So usually to chemotherapy. So I think in the carbotaxol would be my usual approach, possibly continuing the osimertinib depending on CNS disease and other factors.
Corey, do you want to talk about the role of local therapy? So someone has oligoprogression, which we do see pretty frequently. What would you do in that situation?
So if we have what I call oligoremnant disease, where we've had a phenomenal response and maybe some residual tumor, in very select patients, I have addressed that locally with radiation, a couple cases with surgery. Very interesting findings when I've done that. By and large, these are folks who are doing really well, have no signs of progression. Oligoprogression, which is another aspect. Again, excellent control, but after a year, 2 years, 1 or 2 sites, everything else under control. Once more, I have very low threshold to initiate radiation. In the case of liver metastasis, thermoablations, you tailor it to the site. We saw something very interesting today. I don't know if it can be exported to the US per se, but a bispecific monoclonal antibody targeting both VEGF and PD-L1, ivonescimab, I can't pronounce it, in combination with PEM-carbo compared to PEM-carbo, and showed apparent advantage. Now, it's analogous to Empower 150 when you think about it, and that hasn't necessarily panned out, but I think there are many different avenues to choose, particularly when interrogating the areas of progression don't really show a new pathway or a new mechanism of resistance.
Joel, any comments?
Yeah, just quick thoughts. Some of the ones I struggle the most are when we get a BRAF V600E or we get like a KRAS G12C, I see all of these and I'm like, is it a dominant clone? Is it a big percentage? And should I be throwing all these targeted therapies together in ways that we don't fully understand? So I've seen these, but don't know
And what's the answer to that? What do you do?
I'm trying it right now with the BRAF therapies. I've done it before. I haven't tried it with the G12C inhibitors.
I've done OC trametinib, and there's some case reports. I know Zofia had one too. All right. Yeah, go ahead.
You can see all kinds of crazy things. You can see multiple new targets, and then you're looking, just as you said, at the variant allelic frequency to try to figure out what is most dominant. And some of those, I think the MET-targeted therapies have tended to be the ones that are most durable, but a lot of them you just get 3 or 4 months from a second targeted approach.
It's definitely complicated, and exactly like you said, Jonathan, looking at those variant allele frequencies, but you see C797 with MET amplification, it's hard to know where to go first. But Josh is going to tell us more about how we should treat these patients.
Thank you, Helena. I appreciate it. So I'm going to discuss emerging strategies for relapsed metastatic EGFR mutant non-small cell lung cancer. And, the outline of the discussion really is to discuss acquired resistance and the biology of acquired resistance. We're going to focus on some on-target as well as off-target mechanisms of resistance. And you've heard a lot about these already this evening. We'll do a deep dive into MARIPOSA-2. We heard from Roy Herbst that, amivantamab plus chemotherapy in the second-line setting has positive data, PFS. We're still waiting on the overall survival. And then what is the role for immunotherapy in the EGFR mutant population? So let's get going. I mean, what is acquired resistance, right? It's when a patient has a response to therapy and then unfortunately has progression. And, with our targeted therapies, we have not been able to cure patients with EGFR mutant lung cancer. So when you're in the clinic and you get this report back, your exon 19 del patient, and you resequence them and they have an EGFR C797S, are you thinking about that patient differently than an L858R patient who might have benefited for some time on osimertinib and then has a MET amplification? So think about this when you go back to your practices on Tuesday. How do I think about these reports? How do I think about how to act upon these results? So we know that first and second generation EGFR inhibitors have very classic resistance profiles. 50% of patients will have T790M, a point mutation in exon 20. With third generation EGFR inhibitors, as we heard, the mechanisms of resistance are far more broad. Upwards of 40, 50%, we don't identify any resistance mechanism. C797S, about 10, 12%, MET amplification, but it's a large pie of single alterations that can occur. And we can see mutations in the drug target that affect EGFR drug binding. We can see bypass track signaling, and you can also see mutations in downstream effectors. We heard about KRAS just now, very rare, but we do see that in practice. And we also talked a bit about, state transformation, squame transformation, or small cell transformation should clearly be treated differently in your practice. So how do we overcome resistance? So if you're thinking about a selective or on-target resistance mechanism like T790M in the past, we've been very successful with third-generation EGFR TKI. But But post a third-generation EGFR TKI, C797S, our fourth-generation inhibitors have largely been ineffective in development. Again, probably due to heterogeneity of these alterations. What about non-selective or off-target resistance? And you heard from many people up here already. MET, for example, MET exon 14. We see this in a small percent. BRAF, V600E, just told us about a case of yours. RET, ALK, HER2, and this is important to think about in your practice. We have multiple therapies now with novel mechanisms of action entering this space. So, this is thanks to Dr. Piotrowska here, thinking about how do you target individual resistance mutations. So, for example, patients that have acquired RET fusion, do you add a RET inhibitor? And there's some data here showing some activity clinically. Also in patients with ALK fusions, you can actually treat that resistant clone. In my own practice, I have not seen durability using this approach, again, likely due to the heterogeneity of resistance. There are multiple studies. The Orchard study is one looking at a biomarker-directed strategy in post-first-line osimertinib. So if you have a MET alteration, you get savolitinib, a MET inhibitor, plus osimertinib, and so on. So thinking about this in your clinical practice could be very, very interesting. Moving on to amivantamab, which we've heard about already tonight, EGFR c-MET bispecific. We were fortunate to be part of this trial, the Chrysalis 2, which was second-line ami plus lazertinib, post-progression on osi. It was a single-arm study, and you saw overall response rates about 30%, pretty respectable post-osimertinib. But what was interesting is when we looked at MET expression, if patients were MET high, 3+ by IHC, response rates were 60+%. And you can see a lot of these responses are durable in our patients on this swimmer's plot. So that led to the Mariposa 2 study. This is a randomized phase 3 trial, looking at amivantamab plus lazertinib plus chemotherapy versus ami-chemo versus chemotherapy. You see there I have in that red box, chemo versus ami-chemo. That's the subset we're going to focus on this evening. We saw that the ami-las chemo had unique toxicity and really need to be reworked. Primary endpoint here is ami-chemo versus chemo in the PFS by a blinded independent central review. So right off the bat, when you look at response rate, there's doubling of response rates into that 60+% range versus chemo alone of 36%. And when you look at the progression-free survival, here you see a doubling, essentially, of the progression-free survival of ami-chemo versus chemotherapy. Hazard ratios here, 0.48. Now, again, this is nowhere near what you're seeing in the frontline setting. Remember, these are heavily pretreated patients with osimertinib, so these are a difficult or more difficult population to manage in the clinical practice. One thing that we heard from Zofia, and I think we were all relatively surprised to see, was the intracranial progression-free survival. And CNS imaging was mandated on this study, so we obtained MRIs at routine protocol. The utilization of AMI in combination with chemotherapy reduced the risk of intracranial progression or death by about 45%. And if you look at some of the landmarks there, maybe at 12 months, 50% for ami-chemo versus 34% for chemotherapy alone. And we look forward to seeing updated data in the CNS. So overall survival is clearly immature in this patient population. It was only about 8.7-month follow-up. It was 40% mature when we heard it at ESMO. But we're trending in the right direction here. Hazard ratio of 0.77. And we do need to follow and see a positive OS, in my opinion, to see full utilization in the second-line setting. Now, we heard a lot about the toxicity of amivantamab and chemo, and we'll hear more shortly. But clearly, there is an increased rate of toxicity. I think the IRRs have been well managed and mitigated on this study. There is some skin toxicity. But what was interesting to see, specifically on this study, dose reduction and dose hold did not seem to affect efficacy in this regimen. So just one summary slide of this regimen, and I want to focus on ami-chemo versus chemo, those last two there. 64% response rate for ami-chemo versus 36% for chemotherapy, 6.3-month median progression-free survival versus 4.2 months. And look at that intracranial progression-free survival hitting 12 months there, I think quite impressive. Again, unique toxicity profile with this regimen. What about the utility of a PD-1 or a PD-L1 inhibitor in the EGFR mutant space, right? We know not to use it in the front line, but we're all itching. Do we use it in the second line setting, post-progression on osimertinib? So we actually have a lot of data now. So IMpower 150 of Atezo, a PD-L1 inhibitor in combination with Carbo, Taxol, and Bev. We'll talk briefly about the Orient 131 with Sintilimab, Checkmate 722 with nivolumab, and Keynote 789. Unfortunately, a lot of these studies were disappointing, particularly when we looked at the overall survival. So just a subset analysis briefly, and we know this was positive for PFS and OS, it seemed that maybe the addition of a VEGF inhibitor and atezolizumab to chemo had some slight benefit in this population, not something that I'm commonly using in my clinical practice. And here's really the important study, the Keynote 789, which looked at chemotherapy plus minus pembrolizumab, or really I should say pembrolizumab in this setting, in TKI-resistant group. Really no difference in overall survival. These curves are essentially superimposable. When we looked at PD-L1 expression, maybe there was a slight signal. So if you were PD-L1 high or greater than 1%, maybe there's a numerical difference, but still not something that I would utilize in my clinical practice. We know that this is a dangerous regimen to use in patients, particularly in combination with osimertinib. We know that the EGFR mutant patients historically, retrospectively, do not derive significant benefit from immunotherapy. And what's more concerning is the toxicity, right? So if you use these drugs together or even sequentially, there is the risk for increased rates of immune-related adverse events. So despite many exciting therapies, modalities of therapies coming, I would still not use immunotherapy in this patient population. But I hope to see further therapies in the future.
Great. Now we're moving on to Exon 20.
Targeted therapy of patients with EGFR exon 20 insertions seems to be somewhat different than the EGFR activating mutations, and Dr. Haymock is interested in how you're applying the use of amivantamab and other novel approaches to patients with this alteration.
I've got a gentleman who's been traveling to see us from Alabama. He presented with an EGFR 773 insertion. And so, just to remind everybody, with EGFR exon 20 insertions, we start to divide them into near loop and far loop insertions, and it looks like they may respond a little bit differently. 773 is a far loop insertion. I think the question for the panelists, what are you doing for your EGFR exon 20 insertion patients after initial treatment? We know right now we've got amivantamab approved as a first-line option with chemotherapy, but what are you doing after that?
Is that sort of generally now being accepted as first-line therapy by most people?
Yeah, I think so. I think this data is pretty strong. This is the Papillon study, to remind people. And, before we had amivantamab in the second-line setting. So to me, that's a really clear advance. I use this as a standard therapy as first-line right now. But amivantamab does carry the toxicities. We do see the venothromboembolic events, the VTEs. We do have the skin tox and the edema. And then the question is, what do you do then in the second line setting? Because we don't have any other approved TKIs. Now, we've got sunvozertinib and zipalertinib out there. Zipalertinib is a little further along, and they look very promising. So whenever we've got clinical studies there, those would be the natural next option. But right now, we don't have any other targeted therapy options for these patients.
All right, so let's see if we agree with John. So newly diagnosed metastatic EGFR exon 20 patient, is everyone giving chemo plus amivantamab, or are there any that are giving chemo alone? Looks like Josh.
Yeah, I'm doing chemotherapy and amivantamab. I think the data is positive, right? It's the first targeted therapy approval in the frontline setting for this disease, and I think it was practice changing. You have to be living under a rock not to use that regimen in the frontline.
All right, seems like we have consensus. Zofia?
Yeah, I would say I agree. The data is very strong. We'll review it. I do think for an older, frail patient, the toxicities of the combination can sometimes be a little bit tough. And so if I think a patient is not fit for a triplet regimen in that way, then I think still using chemotherapy and then sequentially using amivantamab is the alternative. But I think for patients where we're not worried about the tolerability of that regimen, I agree. I think the data is quite strong for it, and I would use it first line.
I think this is a place, though, where we really need an oral therapy.
Yeah. Absolutely.
And so, speaking of that, I think what novel agents, does anyone have any of these clinical trials open? And what sort of investigational exon 20 drugs are people most excited about? Joel?
This is a space that's open right now in clinical trials, although Zofia is going to look at me and say, why aren't you opening my ECOG Akron study of double-dose osimertinib, which actually does have some interesting efficacy in this population. And now that we have amivantamab in the frontline setting, I think there still is a role for EGFR TKIs that are particularly targeted. We were involved in many of the most mobocertinib clinical trials, which went, instead of combining with chemotherapy, went head-to-head against chemotherapy and was not positive for PFS, so didn't continue approval and is now withdrawn from the market. So I'm excited. There are a number of different studies. UCSF has a study, so I refer over there sometimes.
Corey?
So up until very recently, of course, we had mobocertinib, and then its approval was withdrawn. In part because I think ill-fated trial comparing it to chemo alone, and I think that's really the bar that needs to be exceeded. So if in phase 2, somvocertinib and some of the other new agents look better than mobocertinib, hopefully harbor far less toxicity, then I would have some equipoise going back. But it's no longer chemo alone. The bar is now raised with amivantamab and chemo. So we're looking at PFS now of 11, 12 months. That's going to be tough to beat. Certainly the toxicity profiles may make a difference. Historically, until amivantamab came along, I treated these folks the same way I would treat wild-type non-small cell lymphoma. I gave them chemo, often chemo-bev. I was ambivalent about giving them immunotherapy, although many trials would include these individuals. So it's still a relatively refractory group compared to the more common sensitizing mutations.
Quick comment, Josh, and then we have some audience questions.
Yeah, so Papillon, 73% response rate in the frontline setting, chemo-ami, and we're now building on that with sunvocertinib, furmonertinib, and zipalertinib having 80+% response rates. So randomized studies ongoing. And I was going to ask you, CNS, we don't have great, data in those agents. There is an agent we're really excited about, ORIC-114, preclinically and clinically now. We're starting to see some CNS activity, a real unmet need in our population.
Yeah, the exon 20 insertions really do seem to have that same greater than 50% incidence or cumulative incidence of brain metastases. Okay, so some audience questions. One of the things about early stage disease with early stage resected disease or patients that receive chemoradiation, based on the osimertinib data, are you extrapolating and providing or offering different TKIs such as ALK or KRAS G12C? Jonathan?
I think it's one of the most interesting questions. Now, certainly ALK positive I am. We do have data, although that was versus chemotherapy. And in a stage 3 patient, I am often giving chemo and then ALK TKI. I think there's probably is a difference that some of the TKIs are not quite as tolerable, not quite as CNS penetrant, and not quite as active. So I'm not sure that a capmatinib patient, a MET mutated patient, I would. We have a trial with RET, a Libretto 432, so I think that has all the makings of being a positive trial, but of course we'll have to see what that is. One of the interesting questions that I have faced is a high stage, like stage 3 EGFR exon 20 patient. Some of them have come to me with a recommendation from an outside physician to get amivantamab, and I have not done that. I think there's an interesting question whether you think following Pearl's data you would give them immunotherapy, and actually I have had that discussion with patients. But I think to some degree, we may have to address each targetable alteration on its own, although I hope we can draw some conclusions across types.
I think we're dealing with that sort of toxicity efficacy, right, scale. Would anyone besides EGFR and ALK, would anyone extrapolate to any of the other driver mutations just to get a poll? Or no?
I mean, I think it's a case-by-case discussion. I think there's probably rationale to consider it in some of the other oncogenes where we have these well-tolerated, highly CNS-penetrant therapies with high response rates in the metastatic setting. So ROS1, RET, I think there the appeal is strong because biologically we know that, of course, they're different than EGFR and ALK, but there are strong similarities. I think where we have to be more careful is, we can't consider all targeted therapies equivalent. And so I agree that, KRAS-directed therapy, MET-directed therapy, BRAF-directed therapy, both the efficacy and the safety are different than some of those other kind of more canonical EGFR, ALK, etc. So I think you have to make case-by-case decisions, and I would more strongly think about it in ROS1 and RET, for example, than I would the others.
I want to ask one more question. I think that in patients with progressive brain metastases on osimertinib, and just in general, do you continue the osimertinib? And when is the situation where you continue the osimertinib? Josh?
Yeah, so I'll take it. It's interesting that, pre-Mariposa 2 data, this is something I was doing all the time. It was a dogma, right? Continue OSI, you're going to get, ongoing CNS activity. But when we stopped lazertinib in Mariposa 2, there was no difference in those two arms for intracranial PFS. So, I'm not sure we have prospective data there. And maybe some of these agents, like you mentioned, amivantamab or patritumab deruxtecan have good CNS activity. So I'm actually having that discussion now with patients about stopping the osimertinib. It's a tough discussion, though.
All right, Zofia.
All right. So I think Dr. Haymock really set us up nicely for this discussion about the management of EGFR exon 20 insertion positive non-small cell lung cancer. And I think the first and most important point here to take away from this discussion is that these are different than other types of EGFR mutations, and it's really critical to identify these when you get a next generation sequencing report. I will say that it can sometimes be tricky to do so. You get A767, S768. It's sometimes a little bit hard to know, is this an exon 20 insertion or not? The report should be crystal clear in saying that. If it's not, it's always appropriate to go back to the molecular pathologist who signed it out and clarify with them, because it is really important to identify these. They can be quite heterogeneous. We also know that PCR-based testing under-detects these, and so they're really best detected by next-generation sequencing, which I hope is already everyone's standard of care. But for anyone who's still considering PCR-based testing, this is another reason to move towards NGS. So as we already heard about, currently the only approved therapy that we have for these patients is amivantamab. I've already been prepped. We don't have to go through the mechanism of action of amivantamab. You've already heard that. This is an EGFR and MET bispecific antibody, which first received accelerated FDA approval in 2021, so about 3 years ago, for patients with EGFR exon 20 insertions who had progression on platinum-based chemotherapy. And this approval was based on this data from the Chrysalis phase 1 study. Here, 81 patients who had prior chemotherapy received amivantamab monotherapy, and we saw a fairly good efficacy response rate of 40%, median progression-free survival of 8.3 months. And this data set led to that accelerated approval. What we saw with longer follow-up was that there is a subset of these patients who have sustained clinical benefit. Among 114 patients who received amivantamab monotherapy, 42% of them received 12 or more cycles of therapy. And if we look at median progression-free survival in this data set with longer follow-up, we can see that while the median PFS is 6.9 months, about 35% of these patients remain on treatment at a year. And encouragingly, overall survival here from the time of start of amivantamab is 47% at 2 years. So I think we are starting to see encouraging activity here. I won't belabor this point because we've already spent a bit of time talking about amivantamab toxicities, but main messages here are really you have to watch for EGFR-related toxicities, which are primarily dermatologic, some MET-related toxicities, including edema, and then infusion-related reactions, which until now have led to this somewhat cumbersome administration schedule. But as we saw earlier, and I think we're all very excited about the subcutaneous formulation, which we hope will really mitigate, in particular, those infusion-related reactions much, much lower with that sub-Q formulation. So hopefully in the future, that will be less of a worry, although we will still have to worry, I think, about the dermatologic toxicities, scalp folliculitis, and others, which can be a challenge. Now, as Dr. Haymock kind of set us up for and alluded to, moving from the post-chemotherapy setting, we now have data from the Papillon study looking at the combination of amivantamab plus chemotherapy. I recognize it's confusing. You're hearing a lot of different amivantamab studies. Sometimes it's hard to keep them straight, but this is specifically in newly diagnosed patients with EGFR exon 20 insertions. Treatment-naive patients here randomized 1-to-1 to our old standard of care, platinum doublet chemotherapy, or the combination of amivantamab plus chemotherapy. An important point here is that the amivantamab was given initially in that weekly regimen to minimize IRRs, but then every 3 weeks starting at week 7 to coincide with chemotherapy. And we did have optional crossover here to amivantamab at progression. And as we heard, this was a positive study, I think really compelling data, an improvement in objective response rate from 47 to 73%, improvement in median progression-free survival from 6.7 to 11.4 months, hazard ratio of 0.4 in this data set here, and immature data once again for overall survival, but trending in the right direction with a hazard ratio of 0.67. In terms of toxicities, I think you can take what you just heard about from Mariposa 2, which was done in the classical EGFR mutations, but really just kind of think about it here for Papillon. My takeaway here is that really you're adding the toxicities of amivantamab with the toxicities of chemotherapy, and you really just have to be prepared for both. Neutropenia was slightly higher with the combination. Reassuringly, pneumonitis or ILD was quite low here. And we did see that about a third of patients did require some dose reductions of amivantamab, but overall, relatively low rate of discontinuation. So what does this mean for us? As we already heard from the panel, I think this is something that's being adopted. And if we look at the latest version of the NCCN guidelines, this is a Category 1 preferred recommendation for first-line treatment of EGFR exon 20 patients. Again, as we alluded to, if you have patients where you're worried about the safety of this triplet approach, I think still using chemotherapy first and amivantamab at progression is reasonable. But I think for the majority of patients, we are going to be moving to this first line. What about progression on the chemotherapy amivantamab combination? I think this is where the oral agents right now are where we're thinking about them and studying them, although we all hope that they'll move to the frontline setting in the future. I think an important challenge with EGFR exon 20 insertions has been that structurally these exon 20 insertions push this the C helix into the binding pocket and cause a steric hindrance, which has made it hard for the traditional EGFR TKIs to bind and to have activity. For this reason, there's been now a new wave of drugs specifically developed to be structurally kind of tailored towards EGFR exon 20 insertions. And a number of these have gone through development. We heard about mobocertinib, which was approved and then was removed from the market because of that negative phase 3 confirmatory study. But we're excited about some of the new drugs coming down the pipeline, including this drug, zipalertinib. This was tested in a phase 1 study. This was the dose escalation and dose expansion here. These were all patients with EGFR exon 20 insertions who had had prior platinum-based chemotherapy. And the activity here is shown here. We saw 71 patients who received zipalertinib in this study. 39 of them treated ultimately what turned out to be the recommended phase 2 dose of 100 milligrams BID. And you can see nice activity in the waterfall plot. A confirmed response rate of 38% in all the patients and 41% in the 39 patients who received that recommended phase 2 dose. Median PFS of 12 months, and you can see in the spider plot that some patients do have these durable responses. So I think important to see, and equally important with these agents, part of the challenge with some of the older drugs, mobocertinib, poziotinib, and others that had originally been developed were that some of the toxicities that we were seeing. And I think with this new generation, we are starting to see some improvements. Of course, we still have room for improvement. You can see rash was seen in 82% of the patients treated at 100 milligrams BID, but very few high-grade cases. Diarrhea was seen in only 36% of patients, and you can see overall relatively low rates of grade 3 and higher toxicities. So somewhat encouraging safety profile. Sunvosertinib, another drug on the market here, or in clinical trials here, DZD9008. The largest data set that we have now, although I will say that stay tuned, I think in the rapid oral session there will be updated data with this agent, but for now focusing on Wukong 6, where patients were treated with a recommended phase 2 dose of this drug, which is 300 200 milligrams daily. 97 patients treated here all had prior chemotherapy, a median of 1 to 3 prior lines of therapy, and a very encouraging response rate here, again, in that post-chemo setting of 61%. Median duration of response had not yet been reached. And toxicities, again, overall, the grade 3 and higher toxicities are relatively infrequent, although still about 2/3 of these patients do experience diarrhea. With this agent, we see some CPK increase and rash as well. So, things we still have to monitor for. We also have data for furmonertinib. In the interest of time, I won't go through all of these data, but this table is in the data set for you to review at your leisure. ORIC-114 is a drug we're all excited about, and in particular for the potential for intracranial activities, which has been shown preclinically. And as Joel alluded to, there is some data with osimertinib at 160 milligrams, so double the standard dose, with an objective response rate of 24%. So in the absence of any other clinical trial options, it's something we sometimes reach for off-label. And then I'll just also say that there are first-line phase 3 studies of all of these agents ongoing, and I think in the future our treatment landscape may change even further. With zipalertinib, the phase 3 study is actually a combination of zipalertinib with chemotherapy, taking an approach similar to amivantamab, whereas with Sunvo and Firmo, it's actually TKI alone versus chemotherapy. So these are recruiting. Stay tuned. We look forward to that data. And I will end there, again, with a plug for really remembering to identify these mutations and to test for them. I think all of these options are only available if you really identify the patients appropriately.
Great. So our last module is going over toxicities with these agents, which we've talked about throughout.
Oncologists are now well aware that targeted therapies in oncology often have tolerability and toxicity issues, and our consultant faculty is interested about your practical management of some of the common scenarios involved in the management of EGFR mutant disease.
A couple of questions for the panel. First, what are the main side effects one deals with, especially as we're now doing long-term use of these drugs in patients in the earlier stage setting? Are we dealing with rash, fatigue, diarrhea, interstitial pneumonitis? How often do you see that? And then more importantly, how do you manage it? And what do you tell the patient? How do you interact with them? The second question I have is now as we add chemotherapy in, you could see very easily from the FLAURA2 data that took the toxicity, the adverse events, up 4, 5 or more fold, maybe even more, because you're adding in chemotherapy. There's also the time toxicity, a patient that now has to come in every 3 weeks, and that does restrict patients. So that's something I'd like to ask.
All right, I think first question to talk about is interstitial lung disease. So I think a little bit different than what Roy was asking, but how do you look for this? How do you manage this? And how does it affect your management of patients? Jonathan?
So I think it's really one of the biggest challenges across all of our targeted agents and ADCs. I think the differential is broad. Even infection. Had a patient with PCP pneumonia out of nowhere recently on a targeted drug only, and getting pulmonary involved, thinking about a bronchoscopy, certainly if they're symptomatic. I think in general, addressing it early is good, but one of the challenges is that there are a lot of GGOs that come and go without any adjustment in therapy. So it's careful, close management of the imaging. I do try to review all of my scans, but particularly the ones where there's some new ground glass opacity. I do look, see how bilateral it is, how dense it is, and try to adjust early, often by holding drug.
Corey?
In addition to toxicities, when we see new pulmonary findings, we have to be concerned about progression and certainly intercurrent infections. COVID pneumonia can sometimes mimic some of the findings we see with these various drugs. If it's grade 3 on an ADC, I will stop it and treat with steroids, and I will generally not re-challenge. On the other hand, I've encountered some cases of pneumonitis with osimertinib, again, treated with steroids, and there I have re-challenged, usually with some steroids still on board, like maybe 5 to 10 milligrams a day, and I've been successful. So I guess there's a certain degree of courage I have with the TKIs that I don't have for the ADCs.
I think part of it is how effective the treatment is and how well is it working, right? I think osimertinib or maybe trastuzumab deruxtecan, these are medicines that really provide benefit for our patients. Anyone else brave about restarting retrial? Josh?
So I'm younger than Corey and have more hair than him. So I am more cautious about restarting some of these agents, right? So even grade 1 toxicity, I'm going to lose my hair soon, Tori, don't worry. But even grade 1 toxicities in this patient population, these are patients who are asymptomatic, who have radiographic findings. I actually pause the therapy and I try to mitigate. Once patients have grade 2 toxicity and clearly grade 3 where they're symptomatic, very hard to reverse that. I don't retrial these agents with grade 3 toxicities. Grade 2, if they resume back to no abnormalities, I do feel comfortable restarting.
What about, talking about with osimertinib? So what do you do when someone's on first-line osimertinib, develops pneumonitis? How do you manage that, and what do you treat them with, Zofia?
Yeah, so it's a really difficult situation when this happens, particularly if they're having a good response. I think if they're having, so sometimes they will have very mild ground glass opacities and be completely asymptomatic. I think there you can watch them very closely. I'll often check ambulatory SATs in the clinic to make sure they're not having any, kind of occult hypoxia. But any sign of symptoms or hypoxia, you do have to hold the osimertinib and often treat with steroids. I agree, though. I think for TKIs, if it was mild, if they weren't in the hospital, if they didn't require supplemental oxygen, and importantly, if they were responding to treatment, it is tempting to re-challenge after a careful risk-benefit discussion with the patient. And I agree also often with some low-dose steroids on board to kind of mitigate. And I've had some success with that. I think patients who were really sick in the hospital, who required oxygen, took a long time to recover. There, I'm not brave enough to re-challenge, and sometimes we try a different TKI or move to other lines of therapy.
Any comments about whether it's patritumab deruxtecan or datopotamab, some unique toxicities that you guys have seen that you want to comment on? Joel?
Well, with datopotamab, the thing that sticks out is the stomatitis, mucositis and stomatitis, which looks like it's probably an on-target TROP2 directed effect. And then with all the deruxtecan moieties, it does look like there's this interstitial lung disease, drug pneumonia that we're seeing. I think when I think back about drug pneumonitis, drug reaction, osimertinib and TKIs probably cause it in a different mechanistic way as chemotherapy does, and deruxtecan in particular, maybe more direct lung toxicity of the pneumocytes. And then immune-related, drug pneumonitis, which we're not talking about immunotherapy very much this evening, but immune therapy-related pneumonitis can be pretty well managed with steroids too. So I have different fear of them, but I think I'm most afraid of the deruxtecan-mediated ones.
All right, let's see what John has to say.
Dr. Haymock reviewed current issues related to tolerability of amivantamab, but all eyes are on the upcoming presentation at this meeting of more data from Mariposa, and in particular, data on the subcutaneous administration of this agent.
Amivantamab, we know this is now a standard drug for EGFR exon 20. We're starting to use it more commonly with classical EGFR mutations, and we expect that to expand in the near future. Question is how people are managing the toxicities. And specifically, we've got the infusion reaction, and we're going to hear at ASCO about the subcutaneous regimen and the efficacy there. But what's even more challenging are particular skin toxicities that are a little different than just TKIs. We've noticed a lot of stuff on the scalp and the edema. The edema is something that I can say we've tried drying people out, and they get lightheaded and they shrink up like a prune, but it doesn't seem to help the lower extremity edema. So question is, what has the panel done to manage the edema and the skin toxicity with amivantamab? For the clinicians who are giving amivantamab with the current infusion reaction, everybody gets through this. What I tell patients is I guarantee them they're going to get this infusion reaction. I don't say it's a possibility. I say, assume you're going to get this infusion reaction. And, what I've learned to do is to call the infusion nurse ahead of time. And we find that if somebody hasn't given it before, it seems like an anaphylactic reaction initially. So what I've learned is it's better to call them ahead of time and have the discussion. It's manageable. You follow the instructions, reducing the rate of the drip, and you're dividing it over 2 doses, and everybody gets through it. This isn't a long-term problem. It's a short-term problem.
I think we talked a lot about the IRR, but let's talk about the edema, hypoalbumin and edema. Jonathan, how do you manage that? We see that with all the MET therapies.
Yeah, and especially the older patients, I think, do tend to get it more. And sometimes it truly is dose limiting. Dose holds, I think, do help. I often do try some Lasix, try maybe some compression stockings and get a little bit of benefit, but not major benefit. With the TKIs, I have found more benefit from dose reduction. With amivantamab, I guess I probably haven't taken that same approach too often, but more dose holds.
Any comment? Oh, Josh?
Yeah, I try not to dry my patients out like prunes. They don't like that. And, to be honest, this is a really tough toxicity that happens chronically, right? So it's not up front. You see this many months to years down the road. I have a woman on therapy for 2 years plus now, doing well on amivantamab. And, she was doing fine with no edema for a long time, very active, very mobile. I do find that my mobile patients actually have less swelling. But we started doing wraps, compression stockings, and that's been very helpful for her. I have not found utility in doing Lasix or other diuretics here.
A question that we got from the audience was about moving from toxicity sequencing. So we have different antibodies and ADCs now. How does the panel feel about, say we have patritumab deruxtecan and datopotamab deruxtecan? What do you think about the ability to sequence between these? Zofia?
Yeah, I think it's a great question and one that we need data to answer, to be honest. Both of these drugs have the same chemotherapy backbone, and so I do worry that if you develop acquired resistance, for example, to patritumab deruxtecan, then switching to the same payload with a different antibody is not going to be as effective as switching to a different ADC that may have different components. So, we don't have data here yet. It's guesses. I also surmise that if we don't have other options, we may try it in the clinic and see what happens. But I worry that there's going to be too much overlap.
I think it's complicated. I think for HER3-DXd, we've reported HER3 acquired alterations, and then we've also seen topo1 mutations. And so I think you have to think about resistance to the antibody and resistance to the payload, and we're going to have to get really granular about that and then think about sequencing. One quick question about C797S. Does it matter if it's in cis or in trans? Do you check, Corey?
I check. Again, there's evidence that gefitinib, sometimes the first generation TKIs may actually have a benefit in this situation. I haven't personally seen a response, though.
I've done osimertinib and either gefitinib or erlotinib, and I have seen some responses, or 6 months or so. All right, Joel.
All right. Well, first of all, I want to thank everybody in the audience for your stamina of bearing with us and everybody watching out there. I'm excited to say that despite our toxicity title, that we have a few of the new data slides that were just from the oral, which made it over here faster than the buses did this evening. With that, let's go into this. Here was what I was tasked to do, and I just wrote this because it's a bunch of toxicity. We've seen most of the data, but there is that little carrot in the middle of available results with the subcutaneous formulation of amivantamab. And then one thing I'll note, I've had the privilege of giving an oral ASCO presentation with new data once or twice for clinical trials. There's always the debate. Do you put the toxicity first, kind of emphasize it, and then let everybody just remember the data and dwell on that, when you really impress them, or do you put the progression-free survival and response rate and overall survival, and then follow up with the toxicity so they forget it? So, either way, what we want to do is not memorize the numbers, but talk about management right now. So the first question is lazertinib toxicity profile any different than osimertinib? And as far as we can tell right now, it doesn't look like it is substantially different. The actual dose of lazertinib is a little bit different. It's a higher dose in terms of milligrams, but that doesn't seem to make a difference. This is super small, but basically rash, diarrhea, all the same things we're familiar with managing for osimertinib carry through to lazertinib. Now, I will note, I put that little note down at the bottom, the lazertinib monotherapy safety data from Mariposa, and there's over 200 patients there, haven't actually been presented yet. Even though we saw some survival data, we haven't seen the safety data from that big population of lazertinib. But we'll assume it's the same as the earlier phase 2. Then amivantamab safety overview. You've seen many of these data slides already, but here they are side to side. The Mariposa, which was ami and laser versus osimertinib. The Mariposa 2, which was amivantamab chemo, and we'll disregard the lazertinib for right now versus chemotherapy alone. And then the Papillon, which again was amivantamab chemo versus chemo alone. And across all three trials, I think we could see consistent trends that amivantamab by itself does cause rash, paronychia, scalp rash, acneiform rash, the lower extremity edema, which is very much, I will comment, an on-target anti-MET effect. We see it with capmatinib and tepotinib. And remember, when we're inhibiting MET, this is not mutant MET. The MET itself is intact, so we have to inhibit wild-type MET with all of these inhibitors, even though it's overexpressed in various ways. So amivantamab has the toxicities and side effects that we've been talking about, very much EGFR-like, not unlike cetuximab or drugs like that for community oncologists. But there are some unusual things too. A little bit of interstitial lung disease, but then there's this signal that has emerged of venous thromboembolism, and especially in the combination with amivantamab plus lazertinib, it appears. We'll get back to this a little bit later, but there's a strong recommendation to consider prophylaxis, and NCCN guidelines have prophylaxis, actually say every patient with metastatic lung cancer can receive low-dose oral anticoagulation and prophylaxis. And this is recommended, and we'll get back to a little bit of data showing that it's actually an effective strategy from today. So then, why do we get the EGFR rash? Well, I sometimes describe this as, basically some of the cells in our skin are dying, holes are opening up, the immune system is coming in and reacting, so there's an inflammatory component, but there's also a, defenses are down, the castle wall can be breached by bacteria. So there's the bacterial side effects that we see, pustular things, and then there's the redness and the inflammation. And both of these can be managed, and they can look a little distinct in patients. So EGFR inhibition causes apoptosis of skin cells, causes inflammation in the skin, and also just kind of creates holes of all those junctions. Normally the skin is our best barrier, and it's broken down a little bit. So in 2015, a couple of our dermatologists, one that had worked with me for a few years and started off our program of helping manage EGFR rashes, and then recruited a second person, Sylvania Pugliese and Bernice Kwong. We wrote this article in 2015. Not a lot has changed about the management of EGFR rash. We used to do this all the time for erlotinib. And, when we were trying afatinib, cetuximab, anyone remember those days, right? When we were trying that off-label. But basically, we want lots of moisturizer, help that barrier. Ceramide containing is probably the best, and there's a few different brands. Clindamycin to prevent that bacterial superinfection and overgrowth. Even oral doxycycline or minocycline prophylactically could be very important for this. And then, sometimes like corticosteroids, usually low-dose ones to help with the inflammatory component. Sometimes we'll have patients that actually do fine for 6 months and then get a whole new rash. We've described that's oftentimes like a new bacteria that's kind of taken over their skin flora and then decided to invade into their skin. So not much has changed since 2015, except the dermatologists have rebranded themselves as supportive dermato-oncologists now. Ocular toxicity too, it's mostly front of the eye stuff. So keratitis, scleral inflammation, and then of course the eyelashes that when people are on EGFR inhibitors for long enough grow back and get really coarse and sometimes have to be clipped really short and quite annoying. And the hair gets kind of curly too. So then let's go into subcutaneous amivantamab. These are the only data that were basically available before today, presented by Natasha Lale, and this was at ELCC back in Prague. But now we have some new data too. Basically, amivantamab, as we know, EGFR MET bispecific, and then they presented a 4-week dosing. There's a couple of different doses of the regimen here. Safety profile, about the same as what we expect, except the infusion-related reactions are much, much, much lower. So, on the order of 1 or 2%, and their local reactions in the skin. This is a 5-minute injection of the medication, not a 5-hour infusion like Corey was talking about. So then the Paloma 2 is ongoing, and Paloma 3, phase 3, was just presented this afternoon, and demonstrated that the response rates look similar. So this is basically AMI plus lazertinib, sub-Q versus IV, head-to-head. Should be effective. PKs look the same. PKs were the primary endpoint. But here was the kicker, was overall survival actually looked better with the subcutaneous formulation. So now we have a subcutaneous formulation that, is easier, every 2 weeks right now, but probably will extend every 3 or 4 weeks. And can be given in 5 minutes, not 5 hours, and maybe it even works a little better despite the PKs being the same. So PFS response rate looked equivalent. I'm not sure what to make of this, but it certainly doesn't hurt the case for this drug. Infusion-related symptoms here, so very similar between the two, except much, much less. All the other toxicities very similar. Infusion-related reactions basically non-existent. HER3 DXd, so asked to comment on toxicity, and we did that a little bit. There's, interstitial lung disease, which we're always worried about, 5% incidence in this trial. And then thinking about the pathophysiology, is it because the drug is being recruited to the lungs and we're getting cell death from chemotherapy? Is there something unique about this? It's not totally clear. But there's been a few publications. This one's about trastuzumab deruxtecan and management of interstitial lung disease. And I'll just offer these to anybody who wants to review them later. But, and also various people have come up with the 5 S's, screen, scan, synergy, suspend treatment, and give steroids, sure. But oftentimes we diagnose this because people are short of breath when walking. I'm not doing prophylactic CT scans or PFTs or anything like that looking for trouble. We notice this clinically when it happens. And here are the modifications. For grade 3 and 4, I think for the DXT moieties, we're fairly worried about rechallenge.
I'm going to try
and
to
then apparently that's not my slide. So
yep. One audience question.
So the bottom line is, when oral ASCO presentations are concluded, they either say toxicity was manageable. I mean, I hope it is always manageable, right? Or tolerable. But really, we have to focus on the data and the efficacy, and that's the primary reason to give the drugs.
One quick audience question, as I think it's a good one. Amivantamab, patritumab deruxtecan, datopotamab. What about this for atypical EGFR mutations? If they're approved, would you do that? Do you think that the data extrapolates, Zofia?
I think we need more data, and I believe we are going to see some more of that data here at this meeting. I think, is it with amivantamab or which? I know that this data is forthcoming. We've seen a little bit of data from the Chrysalis trials with amivantamab, but I think we need more to really be able to extrapolate. For now, I think, it's a little bit hard to do until we see more.
Great. Well, thank you guys for sticking with us on this Friday night. And just a reminder that there are a lot of other research to practice sessions going on, so please attend. Thanks very much. Have a good night.